The American Brain Tumor Association is pleased to welcome you back to our webinar series. Our webinar today will discuss laser interstitial thermal therapy, LITT, an emerging therapy for brain tumors. This webinar is sponsored by Monteris Medical. My name is Antoinette Tu, Program Manager here at the American Brain Tumor Association. I'm delighted to introduce our speaker today, Dr. Paul J. Camerata. In November 2010, Dr. Camerata was named Associate Professor and Interim Chair of the Department of Neurosurgery at the University of Kansas and was confirmed as the chairman in July of 2011. With a very active practice in cerebrovascular and skull-based surgery, he has begun to develop an active program in these fields at the University of Kansas. He maintains an active clinical practice in cerebrovascular surgery, treating over 100 aneurysms a year, acoustic neuromas, and other skull-based lesions. As the chairman of the department, he leads a group of 9 other neurosurgeons and a recently expanded residency program in neurosurgery. He is helping develop a major stroke program at the University of Kansas, and he will be actively involved in clinical research in cerebral ischemia and the treatment of intracranial cerebrovascular disease. Thank you for joining us, Dr. Camerata. You may now begin your presentation.
Thank you very much, Antoinette. It's a pleasure and an honor to be here with the ABTA, who does such a fabulous job with education and support for people with brain tumors. We turn to them all the time, as do our patients. So I wanted to give a shout out and a thank you to the American Brain Tumor Association and also to Monteris for sponsoring this. I point you to their webpage, abta.org, although you've probably already been there. That's how you found out about this webinar. So without further ado, I just want to let you know I have no consulting agreements or stocks in any of the subjects that are going to be discussed today. And wanted to talk to you about laser interstitial thermal therapy. And that's really a mouthful. LITT is how I will refer to it oftentimes during this presentation. And I will try and keep things to a level that everybody can understand. I realize we have all different kinds of listeners and viewers out there. So at the end, there'll be an opportunity for questions. And if you didn't understand a particular slide, just let me know. So I thought I would start by introducing LITT, or laser interstitial thermal therapy, by saying, what is the laser? We have lasers in our pockets sometimes. There are lasers that are used as weapons. We use lasers in the treatment of many medical illnesses. But what is a laser? So it's just a little brief outline. So what is a laser? We'll give a little history, a very brief history of lasers, and then what actually is LITT and how it is administered, who it applies to, who benefits from LITT, and then maybe some things in the future that we'll have an opportunity to get into. LASER is an acronym. Okay, so the word laser stands for light amplification by stimulated emission of radiation. It was first described by Mayman in an article in Nature in 1960, and it was based on the theoretical work of this gentleman right here, Dr. Arthur Schawlow. Schawlow and Towns actually won the Nobel Prize for this, and I had the distinct honor of being in a class, a little freshman physics class at Stanford with Dr. Arthur Schawlow. Little did I know at the time he was the man who invented laser. And so laser is really a highly focused light. And here is an example of a laser that's being focused, and a little bit about how it happens, how a laser is actually made. I thought I'd give you a brief little 1-minute video on my go-to source for all things physics related to help really bring it down to understandable words, to Minute Physics on YouTube. And the author of this video has given us permission to view this during this webinar. So this is just a little quick video on how a laser is made and what exactly is a laser.
To make a laser, all you need to do is give a big collection of atoms enough energy so they're excited, ready to emit light. Once one of them spontaneously emits a photon, it'll stimulate two mirrors and let it bounce back and forth through the atoms. All that passing light will stimulate them to emit even more light, and as long as you keep on re-exciting the atoms, they're happy to go on emitting light forever. So why do the atoms emit light just because another photon passes by? It's actually pretty simple. Imagine flipping two coins. They can either be in the same state or in different states. The photons aren't like coins. No matter how hard you try, you can't tell one apart from another. So in a photon flipping experiment, that means there's only one way for them to be in different states, but two ways for them to be in the same state. So they're more likely to be in the same state. And in general, this implies that photons always want to be like other photons, have the same phase, polarization, and go in the same direction. And what's more amazing is that if a solitary photon passes by an excited atom that could emit another photon, there's a good chance it will emit one, because the two photons want to be together, even before the second one exists. So once you have all these friendly photons bouncing around between the mirrors, you can just open up a little hole at the end and let out a blinding stream of coherent light, a laser beam. To see lasers in action, check out the Your Hand in Front.
So that is how a laser is made. You can see it's pretty complicated compared to, when you just pull that little laser flashlight out of your pocket and shine something on the wall. It's actually very complex how a laser is made. And so we'll talk a little bit about the uses of lasers in medicine, and specifically its use in the brain. So these are sort of the movie example, or the movie concoction of what a laser actually is. It's been going on really in movies for many years. The first use of a laser in the brain, however, was about 50 years ago. So 1966, when Hubert Rosenhoff and Fred Carroll did it in Pittsburgh. At that point in time, they used a laser in the brain, first of all in animals, and then eventually in humans who had what was believed to be incurable or inoperable brain tumors. So they would expose the tumor, shine a laser into it, and see if it had any benefit at all, as opposed to what they were doing at the time. Now, get a load of what the laser looked like. Really a far cry from the little flashlight laser that we use to present our presentations, etc. So this is the laser, very bulky, very large, and you can see not really something that you could use in an operating room. So the laser itself was first proposed as a handheld tool in neurosurgery in 1970. There was much enthusiasm. I remember as a young resident 30 years ago that, wow, could we actually use laser in the brain? But there really wasn't much to it. It would char the tissue, it would burn the tissue. It just never really took off as a tool that we could use in our hand to do anything with brain tumors. So for years I've been asked, can you use a laser to treat my tumor? And finally, I can answer that in the affirmative. Yes, we can, and it involves LITT, or laser interstitial thermal therapy. So see the word thermal. It's all about heat. So it was first proposed in 1980. Could we use laser to treat brain tumors with this interstitial therapy, meaning that we place the laser actually into the tissue, and it's all about the heat generated from the laser. So there's light from a small laser fiber inserted into the brain, about the size of a pencil lead, and that laser then generates heat, and the heat kills the unwanted cells in the brain, and those can be tumors or other lesions as well. So it was first used in the brain in 1990, and it's been used in many other organs. And its use has been limited, though, because of a couple of reasons. Number one, you cannot control charring at the tip of the laser, so you could char the tip by leaving it in the tissue. It forms just like charcoal around the end of the heat. And then you couldn't watch what they were destroying in real time. So in other words, you could stick the laser into the brain, but there would be no way of watching it. And so you just kind of look at your watch and say, I'm going to burn whatever's at the tip of this laser for X minutes, and you would hope that you're not going to hurt anything or destroy any very important tissue. But the advent of that has changed with the advent of what we call MR thermometry. And that allows us to watch in real time what the laser is doing in the brain. It's a fascinating technology that has been developed over the last few years and really has brought this to the fore in the treatment of neurosurgical disease. So there are several ways we use laser in medicine. The non-contact laser fiber optic device, so that's where you shine the laser at something and it creates its destruction that way. There's the contact, where you actually take the laser and touch something with it, and it does its damage that way. And then there's the interstitial, and that's what we're talking about here, where the laser fiber is actually placed into the tissue, and it does its damage that way. So how far does the light penetrate? A lot of studies done that show that this particular laser that we're using in the brain may penetrate sometimes up to 4 centimeters in diameter. So it means we can kill something other than just a small pea-sized object. We can kill something that is up to 4 centimeters in diameter from where we put this laser probe. So is it safe? That's another thing people want to know. If we take a laser and put it into the brain, how likely is it to do damage that we don't want it to do? So again, first used in animals, looking in animal brains, creating lesions. And these are slides looking under a microscope to show that the actual lesion cutoff, in other words, the margin, is very sharp between dead tissue and live tissue, meaning that you can create a very nice focal lesion without spreading greatly to surrounding tissue. You can see another example of it here on the cross-section of a brain, a very tight margin between dead tissue and all the live tissue around it. And this is what we actually see on our computer monitor when we're creating a laser lesion, and I'll show you more examples of that in a moment. What is LITT like? How does it differ from normal brain surgery? What sort of is the process that the patient goes through on the day of surgery? So here's an example of standard brain surgery to remove a tumor. This is a large tumor inside somebody's head. You can see normally we'd have to make a large opening to get to it. This is not the particular opening that we would make in this person here to get to that tumor, but just gives you an example of the very large skin incision that we oftentimes have to make to get tumors out of the brain. Well, here's what we're talking about when we talk about minimally invasive laser surgery. The skin incision literally is only this big. So just big enough to allow passage of that probe through the skin, through a small hole in the bone, down into the tumor. And all of the work is done then in the MRI scanner with the laser in this position. So the recovery, you can imagine, is dramatically different, from recovering from a normal brain surgery where we have a rather large incision. There's a significant amount of pain associated with it, and people are often in the hospital for 3 to 7 days. For LITT, where we first started bringing people into the hospital and watching them for a couple of days, now many patients go home within 24 hours and really are not even admitted to the intensive care unit for a brain surgery, which is really, really something. So the benefits: small incision, quicker recovery, shorter hospital stay, less pain, and less damage to the brain. So how is the surgery performed? The patient is anesthetized. I'm not sure where all that noise is coming from, but it would be really nice if we could get rid of that. The patient is anesthetized, and the head is placed in a rigid frame. You can see a little bit of that here. The patient is placed into the MRI scanner with the frame placed on the head here. The MRI is then performed. The appropriate trajectory is established, and then a tiny incision is made. I showed you that on the previous previous slide, and a hole is drilled in the skull about the size of a straw. So we're talking something fairly small. And then the surgeon places the laser into the lesion. The laser is delivered, and the thermal monitoring takes place in a separate room, so in the control room of the MRI scanner. And then the laser frame is removed, the patient awakens, and oftentimes home in less than 24 hours. The whole procedure takes maybe 3 to 6 hours, depending upon how many passages of the laser we have to make and how difficult of a lesion we're talking about trying to contour the laser to. So I will often talk to my patients and say, yes, we have a little tiny pencil-sized hole in your skull. And they say, well, why does it take 4 hours? Well, the actual process is we take the head, we put it in a frame here. That takes 15 to 20 minutes. We go in and do an MRI scanner. So the patient then goes into the MRI scanner, whether that's in the operating room or in a separate MRI suite. And then a number of scans are done. The appropriate trajectory is determined. Then the patient comes out of the scanner. On the other end, we place a small little frame on the head which shows exactly where to put the catheter and the laser. We drill the hole in the appropriate place, and then we go back into the MRI scanner. And the MRI scanner then actually takes us to show that the laser is actually in the appropriate place. And then we go back into the MRI scanner, and then from the computer that controls the laser, I then make all of my adjustments. The robotic driver that drives the laser in and out, I tell it how far to pull the laser in or out, and then I go ahead and fire. So the actual firing of the laser to destroy the tumor only takes sometimes 20 to 30 minutes, but the procedure itself takes quite a while around that. Here's the actual robotic device that is attached to the head. So here you see someone who is really face down, sound asleep. The head is being held in a rigid frame here. A small hole is drilled here, and then we have this device. There's a small device placed here that helps us determine the exact trajectory. We place a bolt after drilling a small hole and then mount this little robotic driver, and then the laser is placed in there. And so then from a separate place, I can control the movement of the laser in and out of the head, and I control how much of the laser actually fires and for how long it fires. So again, sort of this hardware, the patient's head goes into the MRI scanner there, and then I sit on in another room even, just a little bit separate from the MRI, and actually control the screen that fires the laser. Now we have two types of lasers. We have one that fires diffusely throughout, in other words, it gives off a beam that radiates out in all directions, and then a directional laser. So in that way we can control lesions that are not entirely round or spherical. So here's kind of what it looks like. The patient is over here. You see the feet coming out of the MRI here. Here's the device that we've implanted. And then in a separate room, I sit in front of the computer here and go ahead and fire the laser, which looks something like this. This is what I see. I see 3 slices through the brain, and each of those slices are 5 millimeters apart. So for instance, here is the tumor, and these 3 slices are what I'm seeing right here. There you see the laser tip, and I can see where the laser goes. In other words, I can take a little joystick and move the laser down or up. And then every 8 seconds, we see the heat starting to develop around that. So if it starts to go a little too much in one direction, I can stop it, move the laser again, etc. If it looks like it's doing exactly what I want it to do, I wait until the tumor is covered by one of these lines showing that all that tissue has died. And this is the beauty of this procedure. As I mentioned before, we could never tell how much of the brain we were lasering. Now we can, because every 8 seconds it's updated. And as the tumor heats up, we begin to see these lines show up. And the lines tell us that everything within this yellow line, for instance, is the equivalent of being at 43 degrees Celsius or 110 degrees Fahrenheit for 2 minutes. Everything in the blue line is the equivalent of that for 10 minutes, and everything in the white line would be the equivalent for 60 minutes. So we like to treat the tumor to this blue line, which means everything inside that line is going to be dead. Again, it looks just something like this. As I'm sitting here robotically driving the laser, this is what's happening to the tumor. Here's an example, just kind of a little cartoon showing you the laser goes in, and in this particular cartoon we're using a side fire laser that's showing the tumor being killed, and then I can rotate the laser with the robot. Again, I never have to go back to the patient's head. I'm doing all of this remotely from the MRI scanner and the special interface that we have. And again, the beauty of it is I can see immediately if there's a problem. So imagine that I'm doing a brain surgery to remove a brain tumor, and I'm looking at things under the microscope, and then I start to close, and it takes me a half hour, an hour, 2 hours, whatever, to close, and the patient goes upstairs to the intensive care unit. Well, there might be some bleeding in the brain that I couldn't see. I can see everything immediately, every 8 seconds, because there's an MRI being performed every 8 seconds during this procedure, so it's actually quite safe. So as you see here, by turning the laser one way or the other, moving it out, moving it in, we can ablate or kill all of this tissue within our field. And this is what I actually see in real time. Again, tumors represented here in blue. Here's the tumor here. These are two different ways of looking at the brain. This is sort of a front back, and this is a side view, if you will, of the brain. But watch here. You'll see the tissue heating up. It's becoming yellow, brown. You see it starting to heat up here. So all this tissue, which was once green, is now heating up. Now I've moved the laser back just a little bit, and I'm watching here. It's becoming brown. You see more and more heat developing, some heat developing in this one and also in this one as well. And again, we just do that to our contours here, and that helps us kill or ablate the entire lesion with the laser. Again, we'll see any untoward effects, such as bleeding, immediately, because each of these scans is being repeated every 8 seconds. Here's another example of how we monitor the tumor and how we use our real-time feedback, or MR thermometry, to see. So when we begin, everything's green. It shows that we're all at the same temperature. And as we begin to fire the laser here, you can start to see it's heating up right there. You see the orange and the brown. And again, at this level, we don't quite see it yet. Now we're turning the laser. You see the arrow. I can turn the laser, and it's firing more in this direction. So if I see I'm not getting enough ablation or kill up here, I turn it in that direction. So you can imagine that in rather short order, you can effectively destroy the tissue in that area, what would take us quite a while to do from an open surgical procedure. So compared with standard brain surgery, at one center, you can see that a craniotomy, that's our name for a standard brain surgery where we remove bone, open the skin largely, etc. That operating time using an MRI, an intraoperative MRI, is quite long, 7 hours. The same procedure using LITT, under 4 hours. So who can benefit from LITT? We're showing nice pictures about killing a brain tumor. What type of tumors are we talking about, or lesions in the brain? So as many of you know from this website, that there are benign tumors of the brain and there are cancerous tumors of the brain, and there's a lot of kind of in-between tumors. There are tumors that begin in the brain called primary brain tumors. That's the word glioma that we all hear about. And then there are words that spread to the brain from somewhere else. Those are called metastases. They come from the lung, from the kidney, from the breast cancer. They can go to the brain. Well, those tumors, you might imagine, start as a tiny seed or a cell that has gone to the brain from somewhere else. And when they grow, they generally stay contained within themselves. In other words, they have a relatively nice capsule around them. Those tumors are ideal for LITT because you can check where that capsule is, and you can fire the laser to cover all of it, and you've taken care of it. The other kind of tumors, the gliomas, while used for LITT, and those were certainly among the first tumors that were treated with LITT, they're not ideal because those tumors tend to spread, and they can spread beyond what we see on the MRI scan. They tend to have little roots that go through the nervous system and the brain neurons around it and supportive structures. So those tumors are, while you can use LITT with them, they're not going to be curative because we're not getting those tiny little seeds that have spread beyond it. Radiation necrosis. This is something that happens after tumors have been radiated, which responds incredibly well to LITT. And certain epilepsy procedures, in particular epilepsy that is caused by abnormal neuronal firing in lesions that really don't belong in the brain, for instance, scar tissue, things like that. We can go in and ablate the scar tissue with the laser and cure people of their epilepsy. One of the real success stories of LITT in the last few years. So it was used, the robotic LITT system was used in the first human clinical trial to treat recurrent and progressive glioblastomas at the Cleveland Clinic and at Case. That study closed in 2009 already, so we've been using this really in humans for the last 8 years. 5 of the 10 patients they treated were deemed to have inoperable brain tumors, okay? Well, what is an inoperable brain tumor? Every brain tumor can be operated on. If you ask a neurosurgeon, oh, sure, we can do it. It's just the damage that's going to be created by operating on a particular tumor. So you can imagine deep-seated tumors way deep in the brain where you have to go through a lot of normal brain tissue to get to it. You're going to create a ton of unintended injury to areas that you didn't want to hurt. And so those tumors we call inoperable, and those are the tumors that are ideally suited for something like LITT. Tumors that nobody would have done a major surgical resection on are now being successfully ablated with this laser. But again, in the case of glioblastomas, or the malignant primary brain tumors, its effectiveness is limited in that we don't kill all of the cells that have gone beyond the margins. Now, but it does do essentially something that is nearly equivalent to open surgery. In other words, it's killing the tissue. What we're not doing is taking the tissue out, but you rely on the brain's and the body's natural sort of phagocytosis systems, or the body's natural way of getting rid of waste. So you've got all this dead tissue in there. You say, well, what's going to happen to it? The body will get rid of it ultimately, and I'll show you some examples of that. So in this particular study, 4 of the 10 patients were still alive 14 months later, and these are patients in whom an operation, many of them, would not have been done because the tumor was too deep and too much damage would have been done. So those authors in this particular article concluded for highly infiltrative tumors such as glioblastoma, surgical interventions, including LITT, are used to gain local control over the tumor mass. That's what I was saying, although they have to be still considered palliative rather than curative, focused on extending and improving the quality of life in patients with this aggressive disease. So the utility of LITT is in patients where the margins can be seen on the MRI, where a gross total removal of that tumor is not feasible or practical, or in certain patients in reduced physical condition who would not tolerate a big craniotomy. This article, which followed shortly on the tails of the previous article, showed that LITT can increase survival in people in tumors in difficult areas, and they compared people that had not had LITT to people with LITT, and showed that LITT was effective in increasing their survival before progression. Again, the problems with LITT for these malignant brain tumors are that those tumors tend to grow throughout the brain and do not have really sharp, definable margins. And that's exactly what LITT does. It's designed to have very sharp margins. So it can be considered palliative in most cases and not curative. So let me just show you some representative cases that have been done for varying entities. So a 70-year-old man with a metastatic tumor in this particular location in his frontal lobe. LITT was applied to that tumor. And here's sort of the planning phase where we have, you can notice he has a tumor here on the opposite side of his head as well, but that one has been radiated. This tumor had already been radiated. However, the radiation was effective for a short while, and then the tumor regrew. And so we planned our trajectory for the laser therapy. And here is the targeted laser, the trajectory of the laser as it's going to pass into the tumor. And one more photo of that. Here's breast cancer in a 48-year-old woman. Again, a metastasis. So this is unlike those cancers I told you about that tend to have tissues that cells that go throughout the brain. This is a breast cancer patient. LITT was applied to that, and this is her scan 1 year later. The tumor has shrunk dramatically in size, and she continues to do well. This is an intermediate grade tumor in a 46-year-old man. These are axial slices of the MRI, and you can see here this little faint white enhancement there, and again there, and again there, something that his tumor had been operated on previously. So he had had a large craniotomy, but the tumor tended to recur. This cropped up a few years after the major surgery that he had. So we thought, is there a possibility of using LITT for this? So we biopsied it, and this is immediately after the LITT ablation. So this is a contrast administered MRI scan showing all of this white is the area that we have killed or ablated. That's where what's called the blood-brain barrier has broken down, so it allows the contrast that we give him in his arm to go into that part of the brain. And this is 36 months after the laser treatment. Really no sign of enhancement here at all in that area where the tumor had been recurrent. So that's an example of a glioma that actually has benefited from LITT. Here's a 58-year-old woman with metastatic renal cell carcinoma, and actually this was a lung cancer, I believe. This is in her thalamus. Okay, the thalamus is a part of the brain that is highly eloquent. A small lesion in this area will create paralysis on the opposite side, and indeed this woman was weak but not paralyzed in her opposite side. So we took a trajectory from the side here, passing the laser into that. Now you can also see, if I were to operate in our standard way, I'm going to have to go through a lot of brain, a lot of normal brain tissue to get to that, even if I use a microscope and some very long instruments. So instead we use LITT. This is the immediate film. Here you see the laser, this view is right down the pike of the laser here, looking right down the barrel. And this is the tissue that was ablated. You can still see the laser actually within the scan. And this is her scan 6 months later, really without resecting anything. This is the little dead area of tumor. Now her tumor eventually recurred in her lungs, and she died of her lung cancer, but she never did have to have a brain operation, and she recovered a good deal of function on her left side without any kind of an open surgery. This is sort of pushing the envelope of LITT. This is a gentleman with what's called a butterfly glioblastoma, or a glioblastoma, which is the worst brain tumor, one that has survival rates in the 1 to 2 year range. And this was a young man, and it's on both sides of the head, and typically that's not an operative lesion. Again, because we say, gee whiz, we're not going to remove all of this tumor. We know that it's spread well beyond the margins of what we see on the MRI, so why even give it a shot? Well, the envelope we're pushing just a little bit in these cases by resecting some of it through a one-sided craniotomy, standard surgery on this side, but then treat this side with LITT. And again, in a gentleman who most people would not have done any kind of a debulking or removal surgery, he was alive 15 months later after LITT therapy and a partial open resection. Now, one of the more exciting ways that laser is helping us is its use in epilepsy. And epilepsy, as you know, is a seizure disorder where people have really uncontrolled seizures or convulsions that happen sometimes multiple times a week, multiple times a month. And many of those patients can be cured when the tissue that's causing this abnormality or this firing or this epilepsy is removed. And one of the primary areas is called the hippocampus. That's the structure here in the medial portion, medial underneath sort of area of both brains. And you can see it here on the cross-sectional images. This is called the hippocampus. And sometimes at birth or for various reasons, the brain doesn't get enough oxygen, and this little area is very susceptible. It's called the hippocampus, and it produces something called mesial temporal sclerosis, meaning scarring of the middle portion of the brain here in the temporal lobe. So typically, we would remove that through, again, a standard brain surgery. Part of the skull is removed. We make a relatively large opening. We cut out a large section of the brain, and then we close. And again, your recovery is 4 to 6 weeks off of work, if not longer, 3 to 5 days in the hospital, a lot of pain, etc. So this person was brought down to the scanner, and we accomplished LITT on the medial area of the temporal lobe by passing the laser from the back of the head into this area, again through a very small opening, and creating this ablation zone around that long sort of tubular portion of brain. And the person is alive and well 18 months after this LITT surgery with no seizures, and left the hospital the next day and went back to work the next week. So in the 3 published series, there have been 17 patients with medial temporal sclerosis and 1-year follow-up who were treated with this, and the mean seizure freedom rate is 55%. Not quite as good as what we can do by removing that large portion of the brain, but pretty darn good, and for a very, very small price to pay. An overnight stay in the hospital and a little nick on the back of the head. And then finally, another deep malignant brain tumor here in the brainstem and the thalamus, treated with LITT. Again, not something that we would ever have dreamed of opening the head and going in and removing for all of the normal tissue we have to go through. And here he was 9 months later with the tumor barely able to be seen and resolution of all of the swelling in the brain around it. So what's the future of LITT? Well, some surgeons are doing multiple laser trajectories. So instead of just the one little pass of the laser, we'll now put it in 2, sometimes 3 times. That does create, as you might imagine, a little bit more swelling, and some patients then have to go to surgery to have removal of that swelling of the brain. So we have to be very careful in some cases where we do more than one laser trajectory. Other physicians are using LITT. There are some research protocols now to break down the blood-brain barrier and allow chemotherapy to reach the tumor, or using LITT to increase inflammation. So if you would imagine, it's not exactly the same as normal surgery because we're not, in most cases, removing the dead tissue or the tumor. We're leaving it there. Well, what does it do sitting there? Well, it actually increases inflammation. Your body recognizes that as a foreign substance, and it may be that there are things that we can do to increase the reaction of the body against that tissue to stimulate the immune response. And then the breakdown of the blood-brain barrier we know happens when LITT kills the tumor, and then chemotherapy that ordinarily can't get into the brain because of the very tight junctions in the brain that doesn't allow poison to get across the blood vessels. Once you break down the blood-brain barrier, then you can use standard chemotherapy that will get in there. And so there have been a number of studies, particularly Dr. Luthard at Washington University, working on that. And then the use of LITT for other types of epilepsy, or for even pain procedures or psychosurgery procedures done for people with chronic pain syndrome, bipolar disease, etc. And we're really in the infancy of the engineering of the LITT fibers. Imagine a laser that's not just a straight tube or a straw, but a laser that's able to move and turn directions and that's flexible at its tip. These are all places that we're going. So we're really just at the very infancy of this form of treatment, laser interstitial thermal therapy. So thank you very much. It's been an honor again to present for the ABTA, and I'd be willing to take any questions.
Thank you, Dr. Camarata. As Dr. Camarata said, he will now take some questions. So if you have a question you would like to ask, please type and submit it using the question box in the webinar control panel on the right-hand side of your screen. Okay, let's see. I have a question here. Is this LITT, is this a first-line treatment, or do you have to have had problems in the past treating your tumor to get LITT?
So that is a very good question. We have used it as first-line treatment in some, like for instance, those cases of deep malignant brain tumors that I showed you. So surgeons, most surgeons would look at that and say, we can biopsy this, and then you get radiation and chemotherapy. Well, cancer doctors will often say, look, my chemotherapy and my radiation is going to do a lot more good if you can get 90% of that tumor out of there, because it's going to work a lot more effectively on, 10,000 cells than 10 billion cells. And so, most surgeons wouldn't operate on that. So we do, in some cases, use LITT up front as an initial therapy. Now, insurance companies, as you might imagine with any new protocols, are, lagging. So it's not uncommon at all that we have to write letter after letter, call medical directors, etc., to try and get approval for these types of therapy, especially up front. Even though in many cases it saves them money. I mean, we're talking about a 24-hour stay for someone rather than 5 days. And so yes, the answer is we do use it up front, although the majority of cases we're using it in now are in recurrent lesions and tumors. Now, for epilepsy, we also use it up front, but there are a number of patients that I've done the standard epilepsy lesion removal because the insurance refused to pay for LITT.
Okay. Is LITT given in conjunction with any other treatments?
Yes, that's it's an excellent question. In almost every LITT case, certainly for primary brain tumors, we also use chemotherapy. Dr. Luthard, as I mentioned, at Washington University is using this chemotherapy that we don't usually use in the brain in a research study. And there are other, and radiation is often given. Now, I would say with metastatic tumors, most of these patients have already had radiation by the time we get them for LITT. So yes, there are other, and I think in the future there will be more and more combined therapies. So Dr. Luthart's using it in innovative ways with other chemotherapy. You can imagine somebody might give an immune drug, something that would boost the immune system right after LITT to go after all of that dead tumor tissue in there, which might activate it against any recurrent tumor. So yes, other therapies are being considered and used.
Can you laser multiple tumors in one session?
Yes, that is something we've done on a number of occasions, especially with metastatic tumors, those that come from somewhere else. It's not uncommon that somebody will have 2, 3, maybe even 4 tumors. It takes a little longer because we have to mount a frame and drill a hole in each place that we're going to pass the laser. But yes, we've done that on many occasions.
Is LITT as effective as Gamma Knife?
So LITT has only been around, used clinically for, like I mentioned, 8 years, but that was the very first. I would say it hasn't really taken off until the last year and a half or so. And so we don't have the data on long-term efficacy that they do for Gamma Knife. That being said, I have used LITT on patients who have failed Gamma Knife. So in other words, patient who has had a radiation for their tumor, and the Gamma Knife was done, and it looked as though it were dead, and it did not grow for 2, 3, maybe 4 years, and then started to grow after that. And it's like, okay, well, now what do? We've already given it the maximum amount of radiation, which is what radiosurgery, which is what gamma knife is. So then we either have to take it out the old-fashioned way or use LITT. So I would say they're going to be complementary kind of procedures, but we don't have the long-term efficacy data for LITT that we do for gamma knife yet.
Thanks, Dr. Camerata. What are the side effects of LITT?
That's a good question. So so anytime you make a hole or an entry into the brain, you are susceptible to infection. So you could have get an infection, the same as, a normal procedure. Maybe even, I would say the risk is probably less because the LITT cases don't take as long, the opening is not as large, etc. So infection certainly being one. Brain swelling around the LITT is one, and we have come to recognize over the last couple of years that when larger tumors are given LITT, that we have to be very careful about the brain swelling around it, either preemptorily or even after the fact, trying to control the swelling with anti-swelling medicines, so much so that we have now taken to going in and suctioning out the dead tissue in a minimally invasive way, following LITT on tumors that are above a certain size or on tumors that have a significant amount of swelling. So, in other words, if you have a brain tumor that has a marked amount of swelling around it, you either wait for the swelling to go away with steroids before you do the LITT, or you do the LITT and immediately afterwards proceed to the operating room for a small little opening to suction out that dead tissue. Otherwise, you risk significant brain swelling. So I would say brain swelling, infection, bleeding is a theoretical risk. Haven't seen it very often in any of our cases, but the beauty of that is we can immediately see that we've caused the bleeding because we're doing an MRI every 8 seconds and then take care of it.
Thank you, Dr. Camerata. Does LITT work in all parts of the brain?
So that's a good question. Different parts of the brain are harder to access, are closer to eloquent structures. But that being said, yes, you can put a laser fiber anywhere that we can access open, and it works effectively. It ablates the tissue at different rates depending upon where it is in the brain. For instance, if the LITT is placed next to a fluid-filled portion of the brain, so there are these things inside the brain called ventricles that contain spinal fluid. If you're trying to laser a lesion that is adjacent to the spinal fluid, the heat from the laser moves into that fluid and does not go so much into the tumor. So it acts as a sink, a heat sink. So if your laser is right up against the ventricle on one side and the tumor on the other, you might have a hard time heating that tumor up because all of the heat from the laser tip is going into that fluid. Similarly, tumors that are very near large blood vessels. Originally, we were concerned maybe, heating this laser next to a blood vessel is going to char the blood vessel and hurt the blood vessel, perhaps. Instead, what we found is that the blood vessel has rapidly flowing blood going past the tip of the laser, and it does the same thing. It acts as a heat sink, taking the heat from the laser tip away. So the short answer is yes, you can use LITT really in the back part of the brain, the cerebellum. You could use LITT in the brain stem. You could use it in the supratentorial space or the cerebrum, the large part of the brain as well.
Thanks, Dr. Camerata. I have another question. If LITT has been around for 8 years, why has it only been used more during the past 18 months?
So the answer is that it takes a while to go through the very important steps to make sure that we're not going to hurt anybody. We have to examine the toxicity of the device, the best indications, etc. And of course, the FDA plays a big role in that, and approval of the device for that. So there was a lot of research that went on for the first few years, making sure that this is a safe thing to do. And so I would say the two major companies are marketing their lasers right now for this, and it's taken a while for them to get the word out. And you can imagine, I mean, we've been doing this now. Again, the initial folks were doing it 8-9 years ago, really seven or 8 years ago. Now it's still not approved, by insurance companies in many cases. There are no specific codes for this that we're allowed to place on our bills to the insurance companies, and so it's a difficult it's a difficult thing. Even if we show, that's why we're hoping that more and more of these cases will come out in the literature proving the effectiveness, and that's the only thing that's really going to turn around the powers that be that pay for this.
Thank you. Can LITT be given more than once to a brain tumor?
Another excellent question. So we thought, well, gee, why not? If the tumor grows back in the same place, why not do it again? Radiation is limited to some extent in that effect. You may know that you can get radiation, sort of the standard radiation, to a tumor once. You can usually get fractionated or stereotactic radiosurgery, two other types of radiation that are very focal. You can usually get that one more time. But radiation effects are cumulative, and the more radiation you give to a certain part of the brain, the more likely you are to get this radiation necrosis, which can be a very, very terrible problem. And so does the same thing happen with LITT? Not that we have seen so far. I've actually used LITT 3 times in a particular tumor, and it was something that over about a 3-year period of time where it would just still keep coming back. We couldn't get the laser to cover, one edge of the tumor well enough that it would keep creeping back on that side, and then once again on the other side. So yes, you can use LITT more than once.
Thanks, Dr. Camerata. Okay, I have time for one more question. What questions do I ask my healthcare professional team to see if LITT is right for me, and also where do I find centers that have LITT?
So you can, I would say that at the moment, academic medical centers are probably the ones that are most likely to have LITT available. You can research the names of the companies that have developed this technology, and they generally can point you to medical centers in your area that have this available. I think so. Any Google search could really get you there. Then you would ask your professional who is treating your brain tumor, is this something that could be done in a minimally invasive fashion with LITT? And if they're not familiar with it, you could tell them what you know about it, and do like I said, a Google search for someone in your area.
Great, thanks. That is all the time we have for today. So thank you everyone for joining us on this webinar, and thanks again to you, Dr. Camerata, for your wonderful webinar presentation. Also, we'd like to thank Monteris Medical for sponsoring the webinar. Besides our free educational webinars, ABTA has a variety of programs available to help connect patients and caregivers with information and resources to help support them in their brain tumor journey, as well as publications and resources for healthcare professionals. For more information, visit ABTA's website at www.abta.org or call the ABTA Care Line, which is staffed by caring professionals, at 800-886-2282. Let's pause for a moment to conclude our webinar recording.